Hi everybody, Dr. Deed Harrison here. Welcome to this case presentation for the CBP Diplomate program, or if you're watching this online on YouTube, it's just one of our recent case reports that was published in the Journal of Physical Therapy Science. This is volume 31, pages 153 through 158, and this came out in 2019. The title of the project is Improving Posture to Reduce the Symptoms of a Parkinson's Case. This is a CBP case report with a 21-month follow-up. Okay, so the cool thing is we report the data and then we have over a year-and-a-half follow-up on this particular case showing stability of the improvements, which is why this was accepted and published in the Journal of Physical Therapy Science. This was done by the lead author, Dr. Justin Anderson, followed by Dr. Paul Oakley, and then myself, Dr. Deed Harrison. This was completed in part for Dr. Anderson's CBP Advanced certification. This particular case comes out of my office at the Ideal Spine Health Center in Eagle, Idaho. Parkinson's disease, obviously it's a neurodegenerative disease. It's a slow progressive disorder causing motor impairments and also causing some type of sensory disturbances and cognitive disturbances. It's associated with classic slow movements, tremors, and really in late stages or later stages, pretty bad gait and balance disorders as well. Classically, it's been treated with the medication L-DOPA for 50 years. This is basically an amino acid precursor, and what it does is it increases the amount of L-dopamine in the brain. Classic studies early on Parkinson's analysis of cases showed that they had a reduction in the dopamine amino acid in different parts of the brain areas, and this was hypothesized to be the primary part of the disorder. The issue is what is really causing the reduction in the L-dopamine and problems with the neurotransmitters, etc. So what we find out though is L-DOPA does improve some parts of the Parkinson's disorders. However, it also causes problems with chronic long-standing use. For example, it'll cause motor fluctuations and dyskinesia, meaning abnormal motor control, abnormal movement patterns in people. It has very little effect on the gait and balance disorders that's one of the primary impairments in people with Parkinson's. It also can cause autonomic disturbances. For example, hyperactivity, sweating, pupil dilations, things like this. So it changes the way the autonomic nervous system is activated. It also can cause, with long-standing utilizations, different types of chronic pain syndromes, sleep disorders, disturbances, problems with mood, and then in long-standing use, again, dementia. This is a pretty serious issue. Now, obviously, it's one of the primary forms of interventions, and in the short term, it really helps. Problematically, it does cause these things over long-term use. Parkinson's and sagittal balance. If you've looked at people with Parkinson's disorders, when it's in the mid to late stage, you'll find that they have a pretty typical altered sagittal plane alignment, and it's shown here in our case. We have anterior thoracic translation and flexion. Then we have forward head translation as well. This is actually classic of adult spine deformity now known in the literature. There's relatively few papers on looking at true postural alterations as it is correlated or associated with Parkinson's disabilities. Recently, however, Mikami et al. Published a retrospective analysis of a cohort of patients with Parkinson's disorder, and they found that there seems to be an association with sagittal plane posture severity and the alteration in quality of life in people with Parkinson's disorders. However, as this was a retrospective study, it was not a treatment analysis study, it leaves a lot of questions unanswered. Number one, what comes first? The sagittal plane altered posture? Is that correlated to the severity of the disease presentation over time? Or does this posture develop as a result of the Parkinson's itself? Nobody knows the answer to that right now. The other thing is, when we intervene to improve sagittal plane alignment and coronal plane alignment, does this play a role in improving Parkinson's disabilities? Now, by no means am I saying we're curing Parkinson's disease. I'm saying, can we impact the pain, disability, and dysfunctions through proper sagittal plane and coronal plane, transverse plane, postural rehabilitation systems, etc. So this particular case is interesting in as much as we talk about a patient with long-standing Parkinson's disabilities that are progressing, and we talk about the rehabilitation of this patient with chiropractic biophysics methods and how this has improved him in the short term and at 1.5+ years follow-up. Looking at this further, our case, 59-year-old male, chief complaint when he presents is chronic low back pain, pretty bad right knee pain. He was a football player, football athlete in his college years. His boys actually play professional football, and he was quite a big gentleman, and he had multiple injuries in the football realm. So if we think about this, back in his day, it wasn't really documented as well in terms of the head impacts that they incurred. So there could be concussive types of trauma that have contributed to the onset of Parkinson's. That's one of the theories. This could be a possible scenario that it may not be the 100% cause, but it's certainly a related factor. The other thing is he has a history of bacterial spinal meningitis. That's an interesting history. Also, he was diagnosed in 2015 after the bacterial meningitis in 2014. He's had spine surgery at L1, L2 with discitis. He's on dopamine neurotransmitter accentuator, and this has modified some of his symptoms, but not all of them. It has not improved his gait and his balance. In fact, he needs a cane and a walker most of the time when he presented. Initial exam findings, man, there's multiple abnormal postures. These are very significant. There appears to be a leg length inequality, a right pelvic lateral tilt, right, called positive RZP. There's also a plus TXP, positive translation of the pelvis on the x-axis to the left. There is also a translation to his right of the torso in an opposite direction of the pelvis, towards the short leg side. So his pelvis is translated to the right, negative TXT. His head is also translated to the right, negative TXH, you can see that. The head is extremely far forward, and we also see a very large flexion and anterior translation. Now, the astute reader or watcher of this, the clinician will notice that there's also some kind of either trunk rotation or pelvic rotation that's occurring there. You can see that in the torso as well. But that would be what we'd call a secondary posture, likely to the leg length inequality and the torso positions. Bilateral muscle spasms, pretty much from the skull down to the mid and upper thoracic spine, and then also in his lumbar spine. It makes sense that the lower lumbar spine is bearing the brunt of this mechanical load. It also makes sense that the upper neck has a lot of tension and spasm and tightness just due to the size of the forward head posture and the size of the lateral head translation. All ranges of motion are really limited. This is classic in Parkinson's cases that have had this for a few years. This becomes rather restrictive in terms of what their movement ability is. There's pain with extension, pain with right lateral flexion in the thoracic spine, and painful lumbar ranges of motion. Basically, on just physical assessment of him, it was noted that there's a resting tremor in the right hand that's quite common and prevalent when we see Parkinson's disorders. A lot of times they'll have it unilaterally, sometimes bilaterally, but it seems to be more often more pronounced on one side. He has freezing episodes where it's like, forgive me, but if you've never worked with one of these patients, it's like all of a sudden it's blank. They're gone. They're not there. It's like even the eyes, when you look into them, they almost gloss over It's like all of a sudden the window is closed or the door is closed, and then they'll come back. There is abnormal gait and ataxia with the classic shuffling on the toes, right? And then the bradykinesia that's assisted with movement. So he's got almost like a motor control problem, which is these abnormal, almost chorea type of movements that do occur at times with him. When he first came in, he had a very difficult time walking up and down our hall. We have a quite large facility. If you've never been here, our facility is about 12,000 square feet. He had to have a walker and a cane, or he had to be assisted at all times. Okay. Also, the patient reported a difficulty with perceiving odors, even strong odors, and his wife said this as well. He doesn't taste the foods anymore. They're basically flavorless at times. So he's got an odor perceptive problem. Obviously, this is affecting the cranial nerves. He's also very skeptical with he and his wife on what chiropractic can do for him. He was referred into the office by a family friend, and he and his medical doctors are very skeptical. There's no way a chiropractic can help. But after explaining what we saw on the exam, we said, you know what, it's worth a try. We don't know how this is going to affect your Parkinson's, but we do know we can help rehabilitate your alignment, improve the spine, and that should at least improve your pain situation that you are experiencing, and hopefully it'll improve the disabilities associated with your chronic Parkinson's. Okay. So the SF-36 was administered. I'll go through this in two different slides to begin with. This is out of the publication on May 2000. Sized anterior head translation. If you look here, we're 67 millimeters forward. Now, what is the cutoff for moderate to severe pain and disability in surgical settings? It's 40 millimeters. So this person is way above a surgical cutoff that's known to cause pain and impairments in the literature. So this is a major problem, a major concern. This is a red flag from a postural perspective. People say, oh, well, you get no evidence on x-ray. And yeah, yes, you do. You just got to realize that there are limits for this in the literature. 40 millimeters is an absolute cutoff for pain and disability. Okay, 67 is what we identified. The curve is intact, but the amount of degeneration down in the lower neck almost mimics a dish type of presentation, right? So we've got diffuse idiopathic skeletal hyperostosis type of appearance in this area. Now, we know that there's been impact injuries. Maybe this isn't true dish, but it's starting to look almost like an arthroptide in this area. When I look at the sagittal plane, oh my goodness, this is horrific, right? The plumb line, the C7 to S1 plumb line is 180 millimeters forward. That is just over 7 inches. Now the cut point for pain, disability, and impairment in the adult spine deformity literature is 50 millimeters. He is more than 3 times that amount. No wonder home encouraged him to do 75 repetitions of each one. The mirror image traction, we did both coronal and sagittal plane traction. We'll show you that. We used the power plates for mirror image positioning, for some gait and balance motor control. We had him use a support, taught him how to do step-ups on there, taught him how to do some squats on the power plate, some single leg stance activities on the power plate, etc., to try to retrain the motor control system. We also did supervised gait rehabilitation in the office and on nice days around the outside perimeter of the building. We're lucky enough to have over an acre here. We have a big parking lot, a big walk area, so on nice days we can actually take a patient out and do some walking rehabilitative activities with them, get them in the sunlight, etc. And these are the things we did with him. Exercise progression. At first, because he's unstable, he doesn't have balance and motor control, we sit on the power plate on a rigid foam platform. We have him adopt an upright posture, translate the rib cage backwards, translate the head backwards. And then what we'll ask him to start doing is also shift the rib cage back to neutral while he translates the thorax posterior and the head posterior. Then what we would do is teach him how to stand up from this position. And then, so we do a stand to sit progression, and we teach him to control his posture while he's standing. This is what we call a squat retraining, right? We want to make sure when he stands, he doesn't adopt an extreme forward posture, because if he has to bend way over to get up, that's a problem, right? This equates to in older individuals. We'll see in other lectures, when somebody is sitting in a chair and they actually have to use the armrest to really push themselves up and get up, and it takes too long. That's called the time to get up and go. The longer you take to get out of a chair and then take your first step, that length of time correlates to the risk of falling, which then correlates to the risk of fracture and pain and disability and death the older we get. So these types of strategies that I'm showing here and that we did, you've got to realize they're very, very important, not just for Parkinson's, but for older people with hyperkyphosis in general and gait abnormalities. We taught him how to squat. You can see his range of motion is terrible. He's been not doing activities like this. He's been in a walker and using a cane. And so we have to retrain the ability to squat. We have to teach him to try to get his torso more upright and not lean forward. Now this is just of the patient doing some of the walking activities that we were teaching him to do. And the exciting thing is he's not using the cane, right? You can still see some of the postural abnormalities are present with him, but if you notice, we've got very dramatic changes in the sagittal plane. Look at the alignment of the thoracic spine, and then look at the alignment of the head in the sagittal plane, and then look at this. We've really corrected the thoracic posture very nicely, but that head posture is still there. Very stubborn posture with this person, but it's improved, right? And so just to show you the progression of the postural changes over the course of care. This is May 2nd, this is July 13th, August 24th, and then September 16th. And this was the interventional phase, not the follow-up one. So you can see, basically we have over 4 months of interventions, and it took 38 to get 38 sessions. But dramatic changes as were occurring, especially in the sagittal plane. On X-ray, 62.7 millimeters down to 46. Now, by no means is that normal, right? But things are improving, right? We're getting a reduction in these translations for multiple reasons. Number one, the sagittal plane is improving, but number two, the head translation is improving to some extent too. This is still a very bad situation. Needs way more care, right? And then the trunk translation, you can see it's improved largely because we put a foot lift and a shoe lift in, but also we were working on that trunk translation posture as well, right? So if I'm going to do another phase of care with him, what am I going to focus on? We're going to focus likely more on correcting the head translation and the head rotation, and then correcting still the sagittal plane deformities. You'll see that the head translation went from 67 down to 36. Now, is it still bad? Yes, it's still bad, but it's below now the quote-unquote absolute surgical cutoff for pain and disability, which is 40 millimeters. Where is healthy? Well, below 20 millimeters is actually considered healthy in terms of it doesn't cause as much pain and disability. Healthcare, we need to change things through one study at a time, one doctor at a time, one research paper at a time, one patient at a time. That's our mission. Limitations, hey, this is a single case report. We don't know if this works for everybody with Parkinson's, but if they have severe postural alterations, why not give it a try? Obviously, a clinical control trial needs to be done. We need to work on a cohort of people that are matched for age and gender and condition, and we need to see how they do, and then we need to move into formal clinical trials. Hopefully that'll be happening in the future. Maybe this case will trigger and stimulate that in the research world. The patient was treated with multiple treatments. We don't know which component led to the greatest improvement, but you know what? It's never a single modality, it's multimodal. You have to do many, many things to get the result that you want to get, right? Like, if you want to change your life, you don't just change one part of your life, you change many facets of your life, psychosocial, social, emotional, and physical. And then things start to work better. It's not just one component. Same way here. Did he get better because Justin was a good caregiver? You know, did he get better because our office is upbeat and energetic and we believe in what we do? I'm sure that plays a role, but that's not all of a sudden why he starts walking and why his Parkinson's actually improves. It should be noted in the literature, and if you read the paper, you'll find the references for this, that exercise alone does not routinely improve the structure of the spine, and it doesn't it directly impact Parkinson's disability like in this particular case. Our case demonstrates the correction of posture in this patient suffering from Parkinson's disorders did in fact result in quite a change in his performance and many of the signs and symptoms. We do know that more research is needed to evaluate the role of correcting posture in these cases. Hopefully this study stimulated your interest. Maybe this will help you in some of the rehabilitation strategies in your office if you're working with Parkinson's disorders. Maybe it'll trigger a patient to actively pursue care in your office. Oftentimes patients need a study to say, hey, there is hope in some of these cases, right? That's why we do this. And it's not about coercing and convincing, it's about educating and seeing, is this an opportunity for us to work with your case and improve you? And we'll document and track it along the way. Let's give it a start. And then lastly, what I want to say is, in my opinion, this case stopped too early. The what ifs always come to mind. What if I had a year with them? What if we could keep doing this? You know, why won't an insurance company pay for this, but they'll pay, you know, $10,000 to $20,000 to $30,000 for a discectomy? But you're not going to pay for an extensive rehabilitation program that gets somebody back with their quality of life and their activities of daily living. This needs to be changed. You know, not everybody can pay this type of money out of pocket. So the healthcare system does need to reassess itself and look at what is actually a proper utilization of funding, right? Obviously, I'm not saying that cases don't need surgery, but I am saying that cases need to be able to receive adequate rehabilitation as long as there's documentation supporting the progressive improvement of this disorder. Thank you for your time and attention. Until next time.